record, and I believe we are now recording. And let me share my screen with you. Okay, can you guys see my one screen that says DATLS case study? I always get kind of confused when I'm in here with two different screens. Perfect. All right. Let's go ahead and get started with this. So our scenario is we have a patient, her name is Mrs. White, who is 45 years old. She is dying of stage 4 ovarian cancer that has metastasized to her brain and other organs. Currently, she's able to communicate effectively. She had been in palliative care for the last few months and has steadily declined. She's admitted onto your floor, which is an oncology floor. And on entering the room, you notice that the patient is quick to smile. She makes eye contact. She reads with her children, and she tries to perform as many of her ADLs as possible. So we have a good scenario for what's going on with our patient. How would you describe the patient on the health and illness continuum? So I want you just to type in your answers, chat in, and let's see where you guys are with understanding this content. And I ask everyone to participate, please. So how would you describe her on the health and illness continuum? Is she healthy? Is she well? So I have terminal illness. She's at peace with the end of life. She's well. So I would say she isn't healthy, right? She has stage 4 ovarian cancer. So she's at the terminal stage of her illness, but she is what we would say well. She's able to read, she's able to converse and talk and make eye contact. So she has some quality of life. And that contributes to a person's state of wellness. But we would not say that she's healthy just because of the present illness that she has going on. And she's coping, right? Would you say that she's effectively coping with her disease process? I like mentally healthy. That's good. Yeah, so she's coping. And again, she's trying to enjoy her moments of life that she has with her family. So what is the difference between palliative care and hospice? Because that's important for you guys to understand the difference. Just type in what you think. Let's talk about palliative care. So what is palliative care? So palliative care is a relief of symptoms longer than 6 months, and that's correct. Very good, Denise. So it's not treating the disease, but it's maintaining those comfort care. So when someone's in palliative care, they've opted not to continue to do anything to try to stop the disease from progressing or try to end the disease. They're not trying to cure the disease. They're really focusing on just their quality of life. So what is hospice care? How does hospice care different from the palliative care? So your big defining difference, and you're right, Nathan, is that in hospice care, patients are diagnosed by a physician of having less than 6 months of living. And again, we're not focusing on treating the disease, we're just focusing on making sure that our patient is comfortable. Many times with hospice care, too, they will not do things to actively treat chronic diseases that they have. So, for example, if a patient has diabetes, if they go into hospice care, they won't treat the diabetes. They will just let death naturally occur in the body because a lot of the medications that they take can actually cause the patient to be very uncomfortable if they're taking them through that dying process. And with palliative care may not always be seen just with terminal patients. It really has to do with the patient's decision not to continue to try to stop their disease process from occurring. But again, your big difference is that 6 month window. Good. All right. Oops. Oh, hang on. Hit the wrong button. Okay. So our patient is in a same-sex marriage with her wife for over 10 years. Mrs. White grew up in a Catholic family, and she has always been close with them. They, in turn, have been very supportive of her family and wife until this devastating diagnosis. Your patient and her wife have been agnostic for years, but will attend Mass during special occasions with her family. They state they're more spiritual than religious, and that's good information to have. So the first question is, what is agnostic? Because it's important that you have an understanding of mainstream religions, what is pretty common. So what is agnostic? What do you think? You believe in a higher power, but not God. Not atheist, but believe there's something out there. Okay, but those are good guesses. So really, they're ambivalent. They can't confirm that there is a God. They can't deny that there's a God. So they're somewhere in the middle. Very good, Amanda. So the belief that nothing is known of a higher power, whether it's God or not. What traditions and religious rites do you find with various Christian and non-Christian denominations? So what things are similar in pretty much all belief systems? So prayer, that's good. Life and death. What else? Eternal life. What about books? Are there certain books that are deemed holy by a lot of the mainstream religions? The Bible, the Quran, the Torah, so different types of books. Mm, what else? How about emblems? Do all or the majority of religions have some type of emblem that is important? Music, okay. How about food? Any kinds of food that may be okay in religions or not okay? Yeah, so you communion, good. So think about the commonalities that you see with different religions. And that can help you as you're dealing with patients and what their religious preferences are, what their cultural preferences are in terms of what you can do and what you can offer. And as long as you treat people with respect, they're going to forgive things that maybe you don't really understand about their particular beliefs. But that's where our communication really comes into play. What should you do as the nurse to make sure that the patient's spiritual needs are being met? Know the needs, ask them. Very good. Yeah, because the first thing the nurse does is to assess. So let's ask our patients, ask open ended questions. That's good too. So ask open ended questions about what the patient wants, how we can assist in them meeting their spiritual needs, and give the patient time to think about different things. This is a brand new spot for this patient and their family members. And then we need to include that in the plan of care because that needs to be shared with the entire team so that everyone knows about their belief system and what we can do as a healthcare team to help our patient and their family walk through this time. So Mrs. White and her wife have adopted 2 children. Additionally, Mrs. White does not have a durable power of attorney for health care or a power of attorney for any other legal issues. So what does that say to you? The fact that she does not have a power of attorney for health care. Who's going to make her decisions if she can't make them for herself? Yes, the legal next of kin, which is going to be the wife. Very good. And that would bump her parents from making those decisions. So there's a lot of tension between the family and the wife of your patient. The extended family is always hovering, whispering to each other, and asking for permission to participate in the care of your patient when the wife isn't present. Additionally, the family would like to perform last rites and other sacraments, and the wife doesn't want that. The extended family has also been discussing how they won't ever get to see the kids again after Mrs. White passes. So lots of family dynamics going on. Who is your first priority in this situation? Excellent. It's always the patient. That is your first priority above everyone. Good. So, how do you address the wife? When you're talking, how would you address the wife? As the wife. Yes, as the spouse. Yes. So I've been talking with your wife, and this is what she's saying. So address her as the wife. How can the nurse best try to bring them all together so that no one feels excluded in a very tense situation? What can we do? We did not sign up to be counselors, right? Or referees. We're nurses. I like that, Katie. Remind them of the patient's needs. Yeah. So, whatever the issue, you can always bring it back to we need to focus on what Mrs. White wants to do, what the patient wants to do. Do you think it would be helpful if the family were to come together and talk about these issues? I like that, Nathan. Offer education, all with the patient at the center. Yeah, make the patient the main topic. That's good, Alexandra. Yeah, I agree. You wouldn't want to do that at the bedside for fear that it may escalate. But, I think at this point it would be a good idea to call counseling services. You could call the chaplain, a caseworker down, and maybe take the family, extended family and wife to a different setting and kind of let them air all that out and talk about it, but not in front of the patient. I agree with that. You personally do not believe that the patient and her wife should be married. What is this called? Homophobia. Oh, that's interesting. Uh, yeah, it's Hannah's got it. It's a bias. It's a personal bias, but it is a bias. Is that okay to have a bias? Do you think it's okay to have a bias? Leave it at the door. It's good. If you ignore the wife and you focus on the family because you don't agree with their marriage, what does that advance to? Yeah, I agree. Keep it to yourself. Do what needs to be done for the patient. It's wrong. Could be negligence. Denise has it. It's discrimination. So if we have this bias, this personal bias, and we allow that to impact our practice, and we ignore the wife and focus only on the extended family, then we have just discriminated against the wife. The wife of the patient is obviously very anxious and stressed about the situation. What nursing interventions can you incorporate in the patient's care plan to ensure that the wife is involved in the decision-making process because she is the legal next of kin? Educate her on her rights as the next of kin. I like that. That's good. You could also educate the extended family on that. May help the wife to feel a little bit more empowered. Ask the patient and the wife who they want present at the end. That's good. Keep her updated about the patient. Be careful of this one, Alexandra, because of HIPAA. Okay. Just because it's the legal next of kin doesn't mean we can automatically share things. We have to clear that with the patient. Review your care plan. Respect boundaries. That's good. The patient and wife. Good. Your patient signs a DNR. What does DNR mean? What's it stand for? Do not resuscitate. Remember that we have different levels of DNR. So some people may sign a DNR that says they want breathing, but they don't want chest compressions, or they don't want to be put on a ventilator, but they want everything else. Or maybe they only want meds. So be sure that you know the level of DNR that they are. Now, remember also who also has to sign this DNR form besides the patient? The provider, exactly. So he has to have the provider signature, also has to have the patient's signature in order for that to be a legal document. If this patient were to go home, they would have to have this DNR form with them at all times in order for that to remain intact. Like if they were admitted into hospice at home, this DNR form would need to be at the head of their bed, because if first responders come in, they are bound by law to go ahead and resuscitate a patient unless they have a DNR form that is active at that time. So the wife becomes angry when she finds out the family feels that they won't get to see their grandkids, and that their daughter has not confessed her sins before her last rites. So again, lots of family dynamics. How might you as the nurse help to diffuse this situation? Step aside, encourage communication. Oh, chaplain, I like that. Provide resources. Who are we going to advocate for? Yeah, we're going to continue to advocate for our patient. You know, I hear what you're saying about being upset that your daughter does not want to receive last rites. I hear what you're saying. I got it. But at the end of the day, this is her choice. She is the one that's going through this, but I hear you. So remember a lot of those therapeutic communication techniques that you guys learned earlier in the semester when you're dealing with these very tense situations. The family wants the chaplain to come and perform last rites. The wife does not want it. How might you as the nurse intervene? We talked about that. The patient is nearing the end of life. What signs and symptoms would she manifest? What are you going to expect to see from her as she's nearing the end of life? A burst of energy can be very common. A death rattle, yes. Decreased respirations, low blood pressure, mottling, their color may change. Are you familiar with Cheyne-Stokes respirations? Intermittent breathing, yeah. They will breathe very quickly, very shallow, and then they'll have periods of apnea. And then their breathing will start up again. And this can go on for several days. I've seen it occur over several days. It's very hard on the family, very hard on them, but it can be a normal course of the dying process. Have you heard of visioning, where patients will vision things that are not necessarily there? They'll see loved ones that have passed on, have conversations with them. A lot of very interesting research out there with the dying process. What qualifies as death? When do we know that our patient has passed? And we can say that to their loved one. What are we looking for? Yeah, so we're looking for no heartbeat and no respirations. Okay. It is defined as no heartbeat, no respirations, and no brain activity. But at the bedside in this situation, we're just going to be looking for a heartbeat and for breathing. And when that has stopped, then we can say that the patient has passed. Who can call the time of death? So it depends on where you work, but typically if the doctor will sign it, then the nurse can call the time of death. So I know when I worked on an open heart floor, we could call the time of death and the ER doc would come up and they would sign off behind us. I know with hospice nurses, they can legally call the time of death. You must provide postmortem care to the body. What are some protocols that must be observed when you're providing postmortem? Yes, treat them with respect. You treat them just like they're alive. What do you mean, eye care, Megan? I still talk to them. I do too, Amanda. Yes, I talk to them. Clean their bodies. Okay. What else? Anything we want to do? What about the tubes in them? Do we leave the tubes in? Do we take the tubes out? Can we discontinue the IV? So if they are not going for an autopsy, we can take everything out. If they're going for an autopsy, good, Denise, then we have to leave everything in. So we take the catheter out, we take the IV out. Had an ME case last night and I couldn't do anything. Yeah, you have to leave it all in place. If they wear dentures and their dentures are out, you want to get their dentures in as soon as possible. If you don't, their mouth will mold and the funeral home can't get the dentures back in. So just remember that. Also, you want to set the head of the bed up so that everything drains down. If you leave them flat, and you don't have to set it up at 90, but put it at a semi-Fowler's position. We often forget about eye care, but you want to preserve their eyes if they want to donate anything. A couple of drops of saline, wet gauze, ice. Okay. And then we want to make them presentable to the family. So we want to make them look like they're comfortable. We don't cover their face with a sheet. We'll put the bedding around them so they look comfortable. Clean up. We may have to change the sheets if there's any blood or any fluids that leak out, which can be pretty common. Get them in a fresh gown, but just make them look presentable for when the family comes in, because the family's going to remember, that last look that they saw of their loved one. Okay. If you do have someone that is donating their organs, and obviously with this patient, she probably is not going to do that, then there are certain protocols that are also in place, like what Megan is talking about with taking care of them to preserve those organs. And it's also important that you evaluate your own feelings. Okay. You have just witnessed someone passing, and someone is now dead. And a few minutes ago, they were alive. And there's a lot of drama, there's a lot of motion, there's a lot of emotion for you. So you want to keep that in check. If you don't, that could be very, very detrimental to your own emotional, mental health as you're dealing with this. Because in a few minutes, you've got to run down the hall to put somebody on the bedpan, right? So keep everything that you're dealing with in check. And if you need to talk to the chaplain or the counselor, be sure and do that. There's no shame in doing that. Absolutely. Walk away and cry. A family is touched when a nurse sheds tears for their loved one. So let's say that you're following up with the family to make sure they're doing okay. You notice when you're on the phone, the mother is crying. The grandfather is taking the grandkids everywhere, being very busy. The sister isn't handling things well and maybe doing some negative coping mechanisms like smoking. And she even has a grandmother that's crying. So lots of family that loved her that are struggling with this. So what are the stages of grief? Do you guys remember the stages of grief that people go through? Denial. Yeah. Anger, bargaining, acceptance is the final one. Yeah. Shock. Shock is a big one too. These people may be shocked for a while before they can really start to deal with their anger and all the things that they're feeling with their loved one being gone. So it's important to reinforce to our family members that grieving is normal and that people do it differently. You know, it may look very different with the grandmother than what it looks like with the sister or with the kids or with the wife, and that's okay. Uh, Families, patients don't go through the grieving process necessarily in a linear fashion. So it may be different for everyone. They may go through it, they may do their shock, and then they may go through their bargaining, and then they may go through their anger. So it's different for everyone. But I think the important thing is for them to recognize when they need to seek help, you know, and the sister may need to seek help. You know, if she's doing some negative coping mechanism. That's right. Very good, Nathan. There is no order. What understanding about the stages of grief can help the nurse assist the family with the grieving process when there's a lot of stress, anxiety, and anger? So think about this scenario and all the different dynamics that were going into it and how you would deal with this situation if you were a nurse. And we, you know, you don't have to answer this. We've kind of talked our way through it, but it's something good for you to kind of keep back in your mind that most likely, you know, you will be faced with situations like this, and you've got to be able to walk your patient through this and to assist their family. Absolutely. Everyone's at a different spot. Okay, what questions do you have about death and dying? We always like to put this up here to show some of the students some, you know, activities that you could do to bump up your luck for that week. If we see anyone doing this, we know it's a nursing student. All right, does that make sense to everyone? You feel like you got a good grasp of that? Okay, good. All right, well, I will turn it over to Professor Davis.
Would you all like to take a 5-minute break, or would you just like to keep going? All right, let's go then. Grab your phone. We're gonna play Kahoot, our favorite game, right? The last one of the semester. Okay. See if I can figure out what I'm doing. Here we go. Volume. There are 31 of you. I would love to see all 31 of you in this Kahoot. Does anyone need more time? You having trouble? More seconds. Try to get Now remember, costal vertebral angle is used to check for kidney pain. And what are your landmarks for CVA? Ooh, that was so long ago, right? Does anyone remember? Posteriorly, right underneath the 12th rib, right? You lay your hand flat and then you provide some light blows. And if they retract in pain, then they are positive for CVA tenderness. Reverse Trendelenburg. Trendelenburg, the feet are up. Reverse, the head is up. Job. Honest Mouse. Good job, Honest Mouse. Remember, you can have 1 inch around the border that is considered contaminated, okay? That 1 inch border. Dried fruit. Dried fruits is your answer. Good job, guys. Why do we put them in a semi-phallic position? Why is that important for a patient receiving? Yes. Yeah. Aspiration. We don't want them to aspirate and get that tube feeding into their lungs. Very good. Oh, wow, you guys were split. So if you say, why do you feel this way? It's almost as if you're applying that the way they feel is wrong or that they should not be feeling that way. So the best answer is tell me more. Tell me more is neutral. It's not implying any undertone about how you feel. It's not going to make them feel any type of way. But if you say, tell me more, then they're going to be able to open up and you're going to be able to get a response out of them. It's the most therapeutic response. Tell me more. Therapeutic communication. Good. Definitely airborne. And what type of room would a TB patient be placed in? Can they have a roommate? Yes, if they have TB too, they can. But other than that, private room. right? We want to prevent atelectasis. Atelectasis happens when those alveoli collapse, right? So that's the reason of an incentive spirometer. We want to keep the alveoli open. Three, two, one. Very good. Urine concentration. Why are the other options not correct? There it is, Grace. Caffeine and meat, right? The only thing that all three of those answers have in common is the caffeine. Two of those have coffee, the other one has green tea. So it's the caffeine that makes them incorrect. Mormons do not believe in ingesting caffeine. Oh, no. Katie, the game pin is at the bottom of the screen. Guys are split on this one too. Highest potassium. Very good. I like to think it's pound cake, personally. What's the problem in the correct response? Yeah, you better be picking up on a respiratory rate of 4. Okay. This is specific to narcotic pain medication, so you need to pick up on that. Yes, very important. Yeah, for sure. False imprisonment. What is assault and battery? What do you actually have to do in order to assault or batter someone? Physically touch them, right? Yes, lay hands. I like that. Megan, lay hands on someone. I mean, Kaylee. Hannah, sorry. Yeah. So false imprisonment is keeping someone against their will. What is lithotomy? Legs up and stirrups. Yes, the position that you go in when you're trying to deliver a baby. What is prone? Face down, flat on your stomach. And then we know what Trendelenburg is, right? What's Trendelenburg? Feet up, head down. Very good. Okay. Very good. Professor Stam talked about this a little bit doing the case study, right? This is part of that Lord, DNR set of orders. In order for you to get anything like this enforced, you have to notify the provider, okay? They don't want a breathing tube, but they might want chest compressions, okay? So anytime you have something like this, you have to contact the doctor first. You guys know I had to do it. I had to throw in a math question. Why are we calling the physician? We really have to understand this. What was your answer that you got when you did your math? There it is, Cheryl. Can't give the right dose, right? Because we can't halfen capsules. We can't break a capsule. So we need to call the physician. Any other answer you put in there, you made it up. Okay? We don't make up things when we're giving medications. We have to be exact. So anytime you guys are thinking about goals, goals have to be specific and they have to be measurable. There has to be a time, right? So that's what we want you to see when you're looking at goals. The most appropriate goal is going to be the goal that includes all those things. And this is the only one that gave you a time frame. It said by discharge. See what I'm saying? Okay. Good job. Yes. That little goat in that picture, that's so me this week. And it's only Tuesday. Guys have to be more like the two over here, more optimistic, not so pessimistic.